everyone, and welcome to our third annual Autism Hope Summit. I'm excited for our next guest. I've known him for years. He is so spectacular. You are going to learn so much in this next hour. He is Scott Smith. He is a physician's assistant, and we're going to be talking about what is PANS or Pandas. And we're not talking about the bear. I know a lot of you are going like, what? We're talking about a zoo? What? No, we're not. We're talking about PANS and Pandas, and I want to introduce Scott now. Thank you for being here.
Krista, it's awesome to be here. We did this a few years ago together. It was one of the best times I ever had. I'm so excited to be part of this. Let me tell you a little bit more about myself, I guess. I started this business a long time ago with Jeff Bradstreet. I've worked with Jerry Carpsnell. I've worked with Dan Rosnell over the years. I've been part of tens of thousands of kids' care. We got into this for personal reasons, as most of us as providers did. So we have a vested interest in trying to figure this out, just like you do as parents. I come from the parent angle as well as the provider angle, so I think I bring a unique aspect to care.
Absolutely, and you've been working with thousands of families throughout the years, and I know that you're based out of Florida, but you see people all over the world, right?
Yeah, that's right. I think right now we're working with about 1,200 kids from around the world right now. Most of our kids actually do not come from Florida. They come from afar. So it's not uncommon for people to travel in, to fly in and see us, spend a couple days or even a week or so with us to get care established. We try to find local care support for them when we can. Otherwise, we'll continue with their care from afar.
And I think that's what I love about, doctors like yourself, is that people are out there going, gosh, there's no medical care in my area. Guys, you don't have to have somebody in your area. There are doctors and medical treatment out there that you can fly to, and then they can work remote with you. And that's what you do, right?
That's right. That's right. Who doesn't want to come to Cocoa Beach and spend a couple days, right?
Right? It's not like you're in the middle of like nowhere and you have to drive 2 hours from an airport. You guys are in paradise over there. And so I love the fact that you do what you do. Like I said, you're one of my favorite people. I've always learned so much from you. And today we're going to be talking about PANS and Pandas. And so before we get on that topic, can we explain what that means? I remember the first time I heard it, I was like, wait, what? I remember being super confused. And I know there's people out there thinking, wait, did he say the bear? So yeah, I know we're not talking about bears. We're not talking about the zoo. So what does PANS and Pandas mean?
So we'll start with Pandas first, because that was the first to kind of hit the medical profession. So this is a pediatric autoimmune neuropsychiatric disorder that's secondary to a streptococcal infection. It's an autoimmune reaction. It creates molecular mimicry where the antibody that's supposed to attack strep cross-reacts and attacks part of the brain. On a little bit more broad scope, we have a newer diagnostic category called PANS, which is Pediatric Acute Onset Neuropsychiatric Syndrome. And this is brought on because we knew that there were cases of pandas that were not necessarily being linked with strep. And so we went back into the literature and we found that in the late 1980s, early 1990s, they actually came up with a diagnostic term called PITAN, not to throw more diagnosis codes at you, where they had several childhood illnesses that led to neuropsychiatric degenerative symptoms. At that point in time, they decided to study strep and follow it as a marker for Sydenham chorea or rheumatic fever, and that's where Pandas came from. It wasn't until about the late 1990s or maybe around 2000 that we actually started hearing the diagnostic term PANS come about. So basically it has a lot of the same physical manifestations, but without the requirement for the strep criteria.
And so why are we looking or talking about PANS or Pandas and autism? Like, how do the two, connect?
That was a really great question. I wrote a paper on this a number of years ago for Autism Science Digest about the challenges of identifying and diagnosing pandas in the autism subpopulation. It's quite difficult. Classically, autism shouldn't have a secondary regressive period. So if you went through your classic autism regression, 18 months, 2 years old, where we have our average kids that we talk to all the time at these conferences, and they regress in autism, that's one thing. If they start telling you like, yeah, well, we were actually on a pretty good track, and then at 4 or 5, we went sideways, or at 8 or 9, we went sideways, that's when we start looking at some of these other conditions that can occur. There's actually a lot of overlap between Pandas, Pans, and ASD. For example, for pandas, we found that it makes autoantibodies to the basal ganglia. They found that in the early 2000s. We knew that it was an autoantibody to the basal ganglia in autism in 1993, thanks to the great work from Dr. Singh. So a lot of the stuff starts to cross over. And when you look at the literature in the classic studies for pandas, the first exclusionary criteria is you can't have autism. Because even at NIH, I think they realized that, man, these are just a little too close for comfort. So it's hard to tell where one ends and the other one begins. And as a parent, when a kid goes into a pandas flare and they don't have a basis of autism, the parents will tell me immediately. I can always tell who's got a really probably high likelihood of having pandas when I ask the parents what happened, and they can look me in the eye and say, on October 1st at 5 o'clock I was watching Dr. Phil and blank, blank, blank happened, because they remember so clear as day, because it's so out of the blue. For us as parents of kids with autism, unfortunately, we start running through things. Well, there's a dietary exposure. Do we have constipation? Do we have this? So it often takes us weeks or months to come to the conclusion that pandas or pandas may have been the culprit, where for the otherwise neurotypical kids, it's a go to bed one night looking normal, the next day you wake up and it's really gone south quickly. So it's a little easier to pick up in the kids who don't have an ASD base.
And is there biomarkers? I know strep obviously is one, but I know that there's other things to be looking at as well, correct?
Yeah, for sure. So especially now with PANS, which is a much more broad diagnostic category, there's a number of infectious triggers. And again, we can go back to some of that research that was done in the late 1980s and early 1990s. They found things like influenza or mycoplasma or Lyme disease, all were known triggers. And we just keep adding to the list all the time. What I believe happens with our kids is that the blood-brain barrier starts to become incompetent. Just like we talk about kids having leaky gut, I believe that blood-brain barrier starts to become quote-unquote leaky. And the immune system cells in the brain, we call them the microglia cells, start to get the signals that the rest of the body's receiving. These are signals that my brain and your brain are not privy to. They don't make it all the way to our brains. And once I get there, the immune system cells of the brain start misbehaving and causing that low-grade microglia activation that we find in our kids. So yeah, there's a number of things that can cause that trigger, whether it be a gut infection or seasonal allergies or any of your classic things like mycoplasma pneumonia, streptococcus, Lyme disease, influenza.
All those fun words. Everyone's like blah, 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 ABC, supercalifragilisticexpialidocious.
Sure.
And what ends up happening to a lot of our families out there, including me. I remember when I was first learning about all this stuff, and I've been in the community 14 years already, and still, guys, just so you know, like these big words, I'm like, we didn't learn this when we were pregnant. We didn't learn this, typically when we were in high school or college, unless we have a medical background. And so that's what's so wonderful about, people like you that are out there saying, hey, this is a medical condition. We need to look at this because it's an overlying, diagnosis. So like you have autism and maybe you have PANS and there's or pandas, and then there's OCD and then there's all this other stuff. But, perhaps PANS or pandas are making it, these other symptoms really almost be exaggerated on our children. And I think that's why it's so hard to get that diagnosis, because you're like, well, I don't know, is he more STEMI, or does she have more tick type, personality right now? Because a lot of these symptoms with autism, we might see a milder version, and then when PANS or pandas hits, it just appears to be a worsening kind of behavior, but you're not sure where that's coming from. And you're right. The first thing we look at least for me, I'm like, diet. Where was the infection? What's going on? Is he sleeping? Is he pooping? Was there a different therapist? Is there a fragrance in the house? I mean, the list goes on and on. Now, how do you diagnose pandas or PANS? Because that seems to be the kind of hard thing, I think.
So technically, they're both what we call clinical diagnosis. So there's no one specific test that says you have it. It's not like we do a throat culture and comes back positive for strep and be like, okay, you have pandas. So you have to have a high index of clinical suspicion. And off of that, it's based off of the history. So when new families come in to see me, like the family that just left the office a few minutes ago that may be late for this, we spend hours trying to get the history together, and we put all the pieces together history-wise, and then we try to fill in with the different biomarkers medically to help to support or disprove a case. With pandas, you need to have a certain set of criteria. You have to have an acute exacerbation of OCD or a new onset tic disorder. That has to be associated with 2 additional neuropsychiatric symptoms, but that's pretty vast. That could include ADHD, worsening of handwriting skills, daytime urinary frequency, new onset enuresis, So there's a bunch of things that could separation anxiety would be on there as well. So you have to meet those criteria, and then we have to have it in relationship with a strep infection or exposure. So positive throat culture, ASO antibodies positive, a brother or a sister with a positive strep culture. A lot of times I think we forget it's not the actual strep that causes the symptoms in pandas. It's our own immune system. Our immune system has kind of gone a little bit awry. So sometimes your body will be exposed to an infection and is able to get it under control really quickly, and you and I would never get sick because of that. But it's that immune system upregulation that may lead to symptoms. So a lot of the parents come in and say, well, I don't really remember little Johnny being sick. But then we take a look at the antibodies in their body making an antibody immune reaction to an illness that they never actually got the full illness to. And that's what creates the symptoms.
And so we know that, Pandas has been around, once you're in the community, you start learning, and it's been around since the 1990s or something. Why are we just kind of hearing about PANS? It feels like PANS is kind of a quote unquote new thing.
Well, unfortunately, Pandas did not hit the ground running the way that it was expected. I think it was expected because they had Sydenham chorea as a base, and they had a lot of similar markers that it would be easily accepted into the medical community. I think the name sounds a little bit silly, and it just was not really widely accepted. So there's been a lot of years trying to prove or disprove the existence of pandas. And I just think the fight was so vehement around that pandas really never came on, although they were doing a disservice because a lot of providers that weren't in the know were seeing kids come in with these neuropsychiatric symptoms on acute onset and then finding out they didn't have a temporary relationship with strep and saying, well, it can't be anything like this, and moving on to a pure psychiatric diagnosis. And so there's probably some mishandling of these cases over the last decade.
And so are there titers? I know we hear about titers often in the autism community. Like, what do the titers look like? What do the titers look like? First, can we explain to those that might not know what a titer is? First, let's explain what a titer is, and then, explain, can we look at titers within that child's body?
For sure. So when your body makes an immune response, it raises up an immunoglobulin, whether it be an IgM or an IgA or an IgG. We're primarily looking at IgGs when you're talking about titers, and we can measure those in the bloodstream. So when we know what the potential trigger was, whether it be mycoplasma or strep or whatever the other infection is, we can actually look at a titer for that. And we can see if the immune system's been activated for that particular type of an infection. Now, sometimes your body will keep a very low level, even though it's elevated, but a little lower than we would expect from an acute infection from a previous infection to stop you from getting other infections. So it takes an index of clinical suspicion for these low-level markers, whether or not we want to call it the neuropsychiatric symptoms. Again, it's based off of the history. So if the history is really strong for pandas and you have an antibody titer, even if it's small, we may more be apt to call that pandas than if you have no acute onset and we have an elevated titer, then you probably just were exposed to strep, just like any other person or kid, and didn't get the neuropsychiatric manifestations. If I may add just for a second though, with the diagnosis of PANS, it's kind of like the Wild Wild West. PANS is a much broader definition category than is pandas. It no longer has the criteria that you have to meet a temporal relationship with strep, but we added a few things on that. We have some exclusionary criteria. You want to make sure there's no other medical conditions that could potentially mimic this, that would be a better diagnostic description of the symptoms than would be PANS. So when I'm working up a case for PANS, not pandas, pandas is a little bit more streamlined. You want to rule out things like lupus cerebritis. You want to rule out like Wilson's disease, which is a copper mismanagement disease. You want to rule out Hashimoto's thyroiditis. There's a few other things too. There's some other metabolic and other medical conditions that could look a lot like a PANS flare and should be treated as such if that's what you find. Recently, we actually had 2 kids come through with diagnosis of PANS from their previous local providers. When we did the full workup, we actually found that both those kids were Wilson's disease, which is really rare. I've been doing this a long time, Krista. I could count the number of kids with Wilson's disease on one hand. I had 2 in 1 week.
Wow.
But you have to look, because you never know when you're going to miss that kid.
That's insane. Now, my thought is, gosh, I'm thinking about all the families that are watching right now going, well, gosh, maybe my child has that symptom, or, maybe that's what's causing this. First of all, how long does it take to, first, figure this out? Like, I know you're looking at some blood work, you're looking at some clinical questions, what treatment does this, is it harmful to then say, okay, I think we have this. We're going to go ahead and treat as though we do have this. Is there any harm in doing that? And how long does the process take to help get this kind of out of that child's system? And, does it lay dormant? Does it come back? I mean, I got a million questions, sorry, but yeah.
No worries. So we get those slam dunk cases where the parents come in and they have a strep culture in their hands, like, look, Billy had a strep infection 2 weeks ago. 3 days later, we have this acute onset anxiety, OCD, separation anxiety. We had to pull him out of school. He won't sleep at night. His symptoms worsen through the day and get worse at bedtime. And then that's easy. Fantastic. Temporal relationship with strep. You have the acute symptom criteria. We don't need any other testing. You have Pandas. Now, if you come in with that and be like, yeah, we were sick, we had some sort of a cold, but our strep culture was normal, our AS were normal, but we have this acute onset. Now we're talking more of a PANS, and we have to work in that exclusionary criteria.
Okay, and then how long, before you start noticing the child's feeling better or doing better?
So antibiotics is going to be your first line treatment, or whatever the antimicrobial that's associated with what you think is the associated infection. Unfortunately, the long-term success with antibiotics alone are relatively low. Here, I find that only about 25% of the kids are able to be managed with just antibiotics alone or antimicrobials alone. And a lot of them are going to be those strep infections that are really clear-cut. We can go on the most appropriate antibiotic. Most of the kids who come in to see me, though, where we suspect it's Pandas or PANS, and we're still waiting to get some of the data back, we'll start them on a prophylactic antibiotic. We usually start them on a 1 month course of an antibiotic, whether that be a penicillin-based antibiotic, or for somebody who's allergic to penicillin, we'll go with zithromycin. That allows us to get a treatment initiated as we're starting to collect our pieces of data until we can figure out exactly what the perfect diagnostic category to put this kid in is.
I've heard some people talk about IVIG. Is that something to help with Pandas or PANS, or no?
Yeah, it can actually help with both. So IVIG is intravenous immunoglobulins, where we take immunoglobulins from other healthy donors. 1 gram of IVIG takes about 300 people's worth of donations. So when you got a kid who's got acute Pandas and they're getting 50 grams, you basically got a small city's worth of immune system. At low doses of IVIG, like you'd use for immune deficiency, this just helps support the immune system. It stops kids from getting sick. But once you get the autoimmune reaction or the inflammatory changes in the brain, the high dose IVIG is needed to cross the blood-brain barrier. It's generally regarded that a dose of higher than 1 gram per kilogram is going to be a neurologic-based dose. For most of our kids with Pandas or PANS who we're treating with IVIG, we're going at 1.5 grams per kilogram every 30 days until we have acute symptom resolution, at which point in time you'd move more into a maintenance treatment plan for both Pandas or PANS. So for neurotypical kids, sometimes only 1 or 2 IVIGs can reset and get them back on track. For kids with ASD, it's a little bit more complicated because, again, there's so much overlap, so you're fighting a much bigger fight.
And do you see any negative side effects from IVIG?
So IVIG, when it's done by a skilled provider, can be very safe. So you'd want to check an IgA level prior to infusing. For kids who have an IgA level that's too low, anaphylactic reaction is a risk factor for IVIG. Once we've cleared that and we determine that you're a candidate and that there's a need, we calculate out your dose. We do a technique here where we prehydrate with fluid, we give Solumedrol, which is a steroid in the prehydration, and then we posthydrate. We also extend the time of the IVIG out a little bit further. So if through the regular doctor, an IVIG would be a 2-hour infusion, perhaps we make it a 5-hour infusion. IVIG is thicker than blood. The IVIG that I use is about 7 times thicker than blood. If you give that product too quickly, it can run a risk factor for stroke. So we really slow it way down, since a lot of our patients are actually nonverbal, so they can't give me those symptoms back, so I'm overcompensating for that. On the downside, the most common post-transfusion, the most common reaction after IVIG is called a post-transfusion reaction. Because IVIG is thicker than blood, it actually pulls water out of your brain. So I guess the best description for us as parents would be, it's kind of like staggering home from a frat party after you did a night of keg stands. Your body and your brain's going to be really super dehydrated, even though you may be fully hydrated from the neck down. And so a lot of our care is supportive care. Ibuprofen, rehydration, things like that. Maybe a little bit of Zofran to help with the nausea and vomiting. Last thing you want is to be mildly dehydrated, get nausea, stop drinking, and create more dehydration because you're no longer drinking. And that's self-limited.
Would an electrolyte, I mean, I know there's electrolyte drinks that are healthy, and we're not just talking Gatorade that's not healthy. There's some
That'd be
really
fantastic.
Good, yeah, would that be good to give before, during, and after?
Yeah, probably more on the post side, because again, we're going to preload with fluids. There's only so much extra fluid the body will handle, so the kidney's actually going to pump that through pretty quickly. But again, we're trying to keep it as diffused and keep it as thinned out as we possibly can. So right now, I'd say we end up with that post-transfusion reaction with more headache or nausea than we can control that ibuprofen. Maybe about 1 out of every 25 or 30 patients right now. which is not bad. It's way better than the national average because of the treatments that we do. On the back end of it, we'll treat with ibuprofen every 3 to 4 hours, again, to decrease the inflammatory response. When we first give IVIG, because it's a foreign protein, if I gave it to you, your body, rightfully so, should say, hey, you're not part of Kristen, and it takes a couple days for it to realize it's there to help. It becomes immunosupportive around day 4 or 5.
Got it. Okay, and do you see tiredness in the child or hyperactivity, aggression, anything?
For the first 3 days, it can be a little bit up and down. You can run a low-grade fever, be a little bit sore muscle-wise, some headaches, things like that. Like you had a mild flu or something like that. Again, we normally can manage it by staying hydrated and staying on ibuprofen. If you don't have symptom control with ibuprofen, that's where we'll write you a steroid dose pack off the back end or the Zofran. So those are there to be used if you need them. I'd say about maybe 1 out of every 30 of our patients have to use those.
Got it. And now when you're talking about PANS and Pandas in the autism community, and maybe, I don't know, maybe there is no type of percentage. Is there a particular percentage, or just maybe in your own experience from you said you're treating 1,200 approximately children in your practice, do you see a particular percentage of children that are getting this? Is this more common than we think?
Well, it's hard to give the numbers because it's so diffuse. We have a lot of kids who come in here that are just coming in for their autism. And then when we get the history, they start telling me, well, we regressed at 7, we regressed at 9, and now John's 14, and something happened, and we're going. And so we start doing a workup for Pandas or Pans, even though the parents didn't ever come in even suspecting Pandas or Pans. And we're really behind the 8 ball. The longer the symptoms go unchecked, the harder it is for us to treat, the more refractory to treatment they become. So some of these cases get really hard where the Pandas have been going on unchecked for several years. It really worries me when we have Pandas going on and are not doing our due diligence or our highest level of treatment to get it under control, because we don't know what the long-term outcome is going to be. We know what happens to people with rheumatoid arthritis who don't take good care of it. We know that their fingers become distorted and that doesn't ever recoup. We don't have enough data, long-term data. We don't have the post-mortem studies. We don't know what a kid's brain looks like after years of Pandas or Pans insult. We don't know that yet. And so because of that, I try to be as aggressive as I can on the front end, because we don't know the data.
Well, and because we don't know the data, and I know that a lot of these people may have had this, diagnosis without knowing it for years. Once we start to treat it, though, is there, does it lay dormant in the body? Maybe like as it goes on pause, and then it can have different flare-ups, or once you treat it, is it just gone, kind of like the flu, and then you don't have to worry about it again?
So that's a great question, by the way. For kids who are neurotypical, I hate using that term, but who don't have a background history of autism spectrum disorder or even maybe ADHD prior to their Pandas, that blood-brain barrier probably became incompetent for an acute cause and should be able to be repaired pretty rapidly and shouldn't have any problems with leaking again. But we know that blood-brain barrier permeability and GI permeability, and they go hand in hand, are very prevalent in the ASD community. So they've probably had periods of time where their blood-brain barrier was permeable, then it got better temporarily, and then got worse again. And so it's really a kind of a mixed bag in there. Each one of those brain proteins is vulnerable to potentially finding a cross reaction. We call that term molecular mimicry. If I may, in Pandas, what happens when your immune system revs up to attack strep, it identifies a small molecule on the surface of strep. It's called the N-acetylglucosamine terminal. It's called the NAG. If that antibody is allowed to cross the blood-brain barrier, it finds a protein in the brain that has an N-acetylglucosamine terminal, but it's no longer strep. Now it's actually part of your brain. So your body directs the antibody at that brain protein, meaning that your antibiotics are no longer going to be successful because it's not strep driving the bus. At that point in time, you have to decrease the acute inflammation, and then hopefully you can find some ways to shut the door so that antibody can't find its way back. Otherwise, every time you get that infection, it's going to find the cross reaction with that protein in the brain. Now, the cross reaction for mycoplasma is going to be different than the cross reaction for strep. It's going to be different for the cross reaction with Lyme. They're all going to find different proteins. That's how we can have a little bit of a difference in how these cases present, depending on what type of antibody is being attacked.
And now, my thought is, I'm thinking, okay, when I was a kid, I used to get strep all the time. Like, I had it probably at least once a year. I remember being so nervous because I could almost feel it coming on, and when I did, I would be down for the count for a good week or so, and I'd have to get antibiotics, and it would hurt so bad. Often there'd be an ear infection with it. It seemed, I don't know why, the two went hand in hand together. And then when I became an adult, and I don't know what that magic happened, but when I literally had this at least once, maybe even twice a year, my entire childhood, my entire teen years. And when I became an adult, maybe around 19 or 20, it seemed as though the strep kind of stopped. I didn't really get ear infections anymore. Suddenly then, maybe I'm 41 now, so maybe in the last 20 years, I may have had strep maybe once or twice total, and I can't barely remember. I know I've had one ear infection as an adult. Where did that go, and is that something that families need to look into their own family history? Is there a higher percentage of our children, if a mother maybe had that kind of history, and I have no idea, but I'm just asking, if a mother had that history, or maybe someone else in the family had that history, would a child, especially those that have compromised immune systems, could they be at greater risk if for some reason the mother, like myself, maybe had strep all the time? And I don't know where it went. It just kind of went away. Maybe it's dormant and I don't want it waking up. It can stay dormant. Because I remember not liking any of that growing up. But yeah, so I'm just curious, is there some connection?
Well, first, there's some maturation that takes place within the immune system. That's why as adults, we don't tend to get strep as often as we did when we were kids. It's not uncommon for us to have, when we get the family histories, that whether it be the mom or the dad or even a sibling, there's usually a history of somebody in the family with recurrent infections. Oftentimes it's the actual patient, but it doesn't have to be. Someone in the family has got a weird immune system response, and that's okay. So like when you got your strep as a kid, it's not the strep that makes you sick. It's your body making an immune response to kick that strep's butt to get it out of there. The last thing we want that immune response to be, because your body sees how strong it is, we don't want that immune response to make it to the brain, because we don't want that fight being taken to the brain. So the healthy blood-brain barrier keeps out. So you'll feel sick, you'll feel tired, you have a sore throat, you have a sore ears, but it never affected your brain. For our kids, that infection moves straight to the brain, because again, the antibodies are being directed now at a brain protein. So now the inflammation that you used to feel in your tonsils or in your ears, that inflammation is now in the brain. Right.
Oh, wow. Now, what about for the siblings or the other family members? Once we know one child has Pandas or PANS, it might be a dumb question. Is it contagious in any way? Is there a way for, because I'm thinking of strep, like we know strep is contagious, right?
Sure.
So is Pandas or PANS contagious? Also, would it make sense for, let's say, neurotypical siblings, maybe they don't show any symptoms, would it make sense to look at their titers? Would it make sense to double check that there's nothing else going on, with the whole family?
If we have a kid that comes to the practice and we suspect that these infections are going on frequently, we'll screen the whole family to make sure that we don't have a carrier. So when you're in a carrier state for strep, you wouldn't get sick from it. You would harbor the strep on your tonsils or wherever we decide to culture it, but you wouldn't make an ASO or anti-DNAs, and you would have a history. I never get sick from strep. So usually what I do is I have all the people say, I go, who in this house never gets sick? And whoever raises their hand, usually it's mom, is the first one we start with. Because again, if you're the carrier, it would not be making you sick. Now, if you had a sibling who was sick all the time and kept getting throat culture over and over and over, that kid's just got really bad luck. If a sibling gets sick and it's a throat culture that comes back as positive, that kid doesn't necessarily have Pandas and can't be the carrier state, because the carrier state would not allow you to get sick. It's the person who has a positive culture, who doesn't make an antibody, who doesn't have an immune system reaction, who doesn't get sick. That's the carrier.
So potentially I could be carrying around strep and not even know it because I'm not getting sick anymore. Is that accurate?
You look fairly guilty, so I think that's plausible.
Because I'm thinking, like I said, when I was a kid, it was strep, it was ear infections. I even had scarlet fever along with strep and ear infections at one point. And
Sure.
that was as a teen. And so should when we're getting our regular physicals, like as a parent, I'm just thinking, what advice can we give to parents? Obviously, if our immune systems are fighting it, doesn't mean we can't be carriers. Should we, when we get our annual physicals, should we at least ask them look for strep, even though we don't appear to be sick?
Yeah, I would let them know, your primary care provider, that there's someone in your house who has got strep-related illness. So I wouldn't go into Pandas, PANS, or anything like that. For people with rheumatic fever, people in their household that live with them would be screened all the time, because if they got the strep infection or people with rheumatic fever, it would start damaging their heart valves. So it's not common to screen the family members on a regular basis. So anyone that's going in for a physical exam, if you say, I have a child at home who has unique vulnerabilities to strep, could you check? I think most primary care doctors would run a culture or titers on you. It's not unreasonable to ask for.
It seems like an easy thing to do as well.
Pretty simple, not expensive.
And so again, so you were saying that you do treat it, and it seems to be the autoimmune. They might be more susceptible to getting stuff. Let's say you treat it inside their body. Does it keep kind of attacking? Like, let's say it kind of goes asleep for a second, and what are some of the flare-ups? What are some of the triggers that could cause a flare-up, I guess, is the question I'm trying to ask.
Sure. So once that inflammatory response, molecular mimicry, autoimmune encephalopathy, whatever we're calling it today is, once it's established, anything that upregulates the immune system in any way, shape, or form could potentially exacerbate your symptoms. So we'll see it on people here who have kids with pandas or pandas. They come down, they get a sunburn when they're here at Cocoa Beach, and they'll get a little bit of a flare, or they'll get a couple fire ant bites, it'll cause a little bit of flare, or even seasonal allergies can cause it to flare a little bit. Seasonal allergies are a particularly interesting one because our kids also suffer a lot from having abnormal mast cells. We know when those mast cells degranulate and mast cells congregate in the GI tract and on the blood-brain barrier, they cause local permeability changes. So this may be, for some of our kids, the reason why these antibodies are allowed access to the brain. There could have been an allergic type reaction that opened up the door to allow the other antibodies through.
Now, when you were talking before about IVIG, what happens if, for whatever reason, they don't respond to that, because that's supposed to build their immune system up? What other treatments are there to help build the immune system? Sure.
So at that point in time, when IVIG fails, I mean, there's other steroid protocols that we can also utilize that would probably come prior to the IVIG. The best responders to IVIG are the kids who do great on steroids but can't maintain their benefits once they get past the steroid course. Then you're talking about things like plasmapheresis. Is kind of like dialysis, where they go in, they strain your blood to take out all the antibodies, good and bad, so you're very vulnerable when you leave. And we often would recommend, if you did a plasmapheresis, to replace with an IVIG afterwards, so you don't walk out in the street and get the first cold you walk by. And then nowadays, for autoimmune encephalopathy, which is really what we're talking about here, there's other biologic agents. Rituxan would be the most common. These are injections that you get on a regular basis. They turn off subsets of the immune system, not the immune system as a whole, like you would with steroids. So while they have their side effects, they don't have this whole giant panacea of side effects that you would have with, say, prednisone.
Okay. Yeah, so now prednisone, I know that there are people that have, and that's a steroid, is that correct?
It is, that's right.
Yeah. So I know there are people that have issues with that. Like I've read on reports, like sometimes aggression can happen and different things. But then I've read that IVIGs help them, even for those people that have had side effects on that particular steroid. Have you heard of anything like that?
For sure. So there's a certain set of side effects that come from steroids in general. So you can get some irritability, some agitation, even some rage type behavior. So it's hard to delineate this. So normally what we would do is our first attempt at steroids for a kid with pandas or PANS would be what we call a pulse dose. It's just 3 days of steroid. During those 3 days is probably not where you're going to see your biggest benefits, because you're probably going to get some relief of inflammation, so some positive gains, but then some increase of side effects from the steroids. So the net gain is probably going to be pretty small. You'd be looking for your biggest improvements the first day post steroids, where there's going to be no steroid side effects and still the inflammation control. That's really what we're looking for with a pulse dose. And we're doing that both diagnostically and therapeutically. So therapeutically, we're doing it because we think that 3 days of being a little bit off with the steroid may infer us a couple weeks or even a few months of benefits. Some kids do great for months post a pulse dose of steroid. For other kids, we're looking more diagnostic. So we know that steroids only do one thing. They decrease inflammatory response. So if we give someone steroids, even if it only lasts for 2 or 3 days, but their OCD is cut by half and their anxiety is gone, it's really easy to make the connection that inflammation is driving those two symptoms. And so we can be a little bit more all hands on deck towards inflammation at that point in time. So sometimes we'll use it therapeutic, sometimes we use it more diagnostic.
And so now let's say that they have this diagnosis, they're doing these treatments. What does it look like after that fact? So what other treatments do they consider long term to kind of keep their child in a healthy state?
So if you, and this is very vast, so I'm just going to touch on a couple of key areas. So if you believe, as I do, that Pandas and Pans is a dysregulation of the immune system in general, and it has to deal with permeability changes at the blood-brain barrier, then one of the best things you can do for the long term is to get a good, healthy small intestine. So a good friend of ours, Dr. Theo, has talked for a long time that the permeability changes in the gut are the same mimicked in the blood-brain barrier. So anything we do to heal up the leaky gut should help heal up the blood-brain barrier as well. So dietary restrictions, getting rid of any bacteria or fungal overgrowth in the GI tract, taking away any allergenic or immunoreactive foods. So allergenic being IgE based, or immunogenic would be IgG based foods. These all go a long way for helping the long-term success for Pandas Pans, especially in our kids with ASD, because that GI tract is just such a battleground.
And so now, what's the message that, you know, for these families, if they have any type of thought, you know, I can just see people going, okay, he just described my child, you know, like I'm seeing this, I feel it, you know, where do I even begin? So, like, what's their first steps that I mean, obviously I would think to find a doctor like yourself that's, you know, specialized in this. Is there something they could do right now today at home to maybe help the symptoms if they believe that prior to seeing a doctor?
So the first thing I would recommend, once you become enlightened to the fact that you'll be Pandas and Pans, is sit down and write as much of the history out as you can, because you're going to have this newfound energy like that you may have found something. So get it all on paper. Be like, man, in November we had this, and we were treated with, you know, amoxicillin in December. He did good for 5 days, and this, that. Get all that stuff on paper. And then the first thing you could do it'd be to do an ibuprofen protocol. So for this, I do the maximum dose of ibuprofen for the weight of the child on the box. And unlike regular ibuprofen, when you give it for pain or a headache, you're dosing it every 6 hours. I usually give the standard dose, but I do it on the 3-hour interval with food so you don't upset the belly. We do it from the time the kids get up till the time they go to bed, so you probably get 3 or 4 doses for the average kid on an average day. And you do that for 3 days. And that works kind of like a steroid challenge that you guys can control as parents. It's imperative that each of those doses be given with food so you don't cause an erosive gastritis or even an ulcer. That's a lot of ibuprofen over a very short period of time. It does cross the blood-brain barrier, though. It does have the right inflammatory response. And I'm sure you know, if you had a headache, Kristen, you might take 400 milligrams of ibuprofen, you may take 2 ibuprofen. But if you hurt your back surfing at the beach, you may take 800 milligrams of ibuprofen. Our little guys can't handle that much ibuprofen at once. So instead of giving a big dose every 6, we give a reasonable dose every 3 at the half-life. So the second dose piggybacks on top of the first, the third piggybacks on the second, so forth and so on. So through the day, you build up to an anti-inflammatory. So it's most inflammatory right before bed, which is usually where our Pandas and Pans kids are doing their worst. They can have bad behaviors anytime during the day, but they tend to crescendo through the day and reach their apex right at the end of the day. Excuse me.
And so what will they see after they do this protocol after 3 days? Like, what are some of the symptoms they might see being relieved?
So, I mean, there's a whole cascade of symptoms that could be improved, but really what we're looking for the neuropsychiatric changes. You know, did handwriting samples get better? Did math skills start to return? Did eye contact get better? Did we see less irritability, anxiety, aggression? Did we see a decrease in OCD? Did we see sleep patterns start to normalize? If you can check a box yes to any of those, you really need to find yourself a good provider. You can start with the MAPS group. You can go on the parent chat boards. These moms are really in the know. As you know, they know everything. They know who to see and when to see them. And someone there will guide you in the right direction.
And so for those that don't know what MAPS are, that's Medical Academy Pediatric of Special Needs. I think the link is medmaps.com or medmaps.org. It's one of those. If you Google that, you'll find that. Now, and so I want to be also very clear. He only said for 3 days, guys, on the challenge. So, you know, if you're seeing good results, don't go, oh, okay, well, I'm just going to stay on this until I see a doctor, because that can absolutely have side effects, correct?
Yeah, so that does concern me as well. So this is a great tool that you guys can control as an initial entity. But then once you make the determination, it's probably not your best long-term solution. And if we're worried about permeability changes, well, the ibuprofen does help with inflammation on the short term. Over the long term, it changes permeability and will actually make the leakiness of the blood-brain barrier and the gut worse. So it's not an everyday protocol. I know there's a lot of people out there that will use an everyday ibuprofen protocol, and at some point in time, it just becomes a break-even proposition. The new permeability changes that you've caused from the ibuprofen are no longer able to be balanced off by the anti-inflammatory effect, so you may have to chase that dose up. So It's not that you
Yeah.
can't do it for more than that first 3 days. It just should be under the direction of someone with medical supervision.
Absolutely, and that's why I wanted to make sure you guys saw that. Gosh, I always learn so much from you every single time I'm around you. Every time I've been at a conference and I've seen you, I mean, you're just the knowledge you have, and you give it in such a way that we can understand, which I love as a mom, because I didn't go to medical school. You know, I joke that we're mother determined, not medical doctor, you know, and that's our MD part behind us. So for all of you guys that are watching and you're thinking, gosh, you know, why did my significant other not have time to watch Scott today? Or, you know, wish my family could have got in on this, because, you know, I want everybody to understand this, and I'm trying to explain it to people and they're thinking I'm crazy, and look at here, he just explained it perfectly. Super easy. All you have to do is go to autismhopesummit.com. You can buy the entire package, and it's over 25 of the top experts in their field. So you can have it forever. Scott can be in your living room every day, which is awesome. And and the coolest part is that all the dollars raised from the Autism Hope Summit goes back to the Autism Hope Alliance, which goes into our nutritional scholarship fund, which means we can help more and more families across the country. So last message, Scott, for those families that are newly diagnosed and they're just thinking, where do I turn? Or for those families that have been on the journey for quite some time and they're still feeling like, I've tried this, I tried that didn't work, this didn't work, why should I try anything else, right? What kind of message can you leave them with?
So this is something that can be managed and can be treated, and sometimes just flat out cured in some kids, depending on the scenarios. Don't let it go unchecked. We don't know what the long-term damage is going to be. Gather as much research as you can. When we have families coming here, it's not uncommon that moms will show up with 4 or 5 binders worth of stuff, and it's my job to sift through it all and figure out what the important piece is. You can go to the Pandas Provider Network. They have a parent section on there. You can go to MedMaps, and they got some information on there. I have some information on my website at centralfloridafunctionalmedicine.com. There's a presentation I did from a few years ago from Autism Canada. There's information out there, and don't be discouraged if you've tried a few things. There's just so many different causes for this. Someone's gonna have to sit down in a systematic order and start crossing off potential pathologies that can mimic it, and really refine your treatment out. So there's things that can be done. So don't give up hope. Every day you should wake up thinking, this today the day I'm gonna come up with the next answer that's gonna take my kid the next step forward.
I love that, and I think that's important for everyone, regardless of where they're on their journey. Every day we wake up and we say, okay, what's next? What's next? I want more. I want more. And if we keep doing that, one, it pushes the doctors and the medical professions to keep searching for those answers. And 2, it reminds us that we're never going to give up hope, because progress for one child provides hope for all. Thank you so much, Scott, for being here today, and thank you guys for watching. Until next time. Bye, guys.